Ladies and gentlemen, I was thinking right now, Orlando Pirates is the only team that won the league in second position. Ladies and gentlemen, the seats are getting filled. I will kindly just request you to move inwards so that we can make space for other attendees that might be joining us late. Apologies for that. And I noticed that when delegates are going to the restroom, we find them outside. Please, just a reminder that the restrooms, they are this side. And as well, we will be having tea at 12 o'clock, and then you will be joined by one of my colleagues who will be emceeing going forward. So now this is our last topic before tea, and it will be done by one of your own from Malamulele, which is Dr. Padin. Let's give him a round of applause.
Morning, colleagues. So let's talk about less slightly complicated stuff. So we're gonna talk about the GEMS dental program. But before we go there, just few things to clear up, because I felt Hautang was being personal this morning. So that child that he spoke about, Matumi, who sits at the back, I am that Matumi, so I'll finish the story. So remind me before I get off the podium to actually finish that story. The second part is the issue of the black car. So my father used to own one of those and other cars. So we used to play with those cars. We used to steal them, but you don't touch the black car. You don't touch the black Chevrolet, otherwise you are in trouble. Before I get into my presentation, I need to touch on what Dr. Mashiho raised, one of our dental practitioners. Because after 2 years ago, we had another healthcare practitioner summit, and because of the number of questions that came from the floor that actually related to dental issues, the scheme initiated what we call virtual dental roadshows. So annually we have 2 of those. There's one coming very soon, and I'll share the details later. So we had one last year, and what we normally do is that for an hour we invite a speaker to talk about clinical issues. So we invited a specialist periodontist, Dr. Muloi. She's based here in Polokwane. So Dr. Lihodi, what we requested Dr. Muloi to talk about was the relationship between periodontal disease and systemic conditions. And you will know that on top of the list is diabetes mellitus. So diabetes mellitus is one of those conditions that they have a bidirectional relationship with periodontal disease. So we know that if you are diabetic, you are at increased rate of having periodontal disease, and your condition is actually worsened if you're actually diabetic. But on the other hand, if you have a periodontal disease, you are at risk of other systemic complications, cardiovascular disease, kidney disease, because your blood sugar control it's just goes way wide. She spoke about referrals. So we raised that heightened issue to say, refer these patients to medical practitioners to actually manage them. And Dr. Chauke, It goes to the point that you raised 2 days ago in another forum that myself and you attended when you said we divide the patients into organs and hope that the patient will be whole. We need to start managing the patient. And that's exactly what we try to do, to say, let's manage a diabetic patient holistically. But to close my case here is to say to medical practitioners, let's refer these diabetic patients to oral healthcare practitioners to manage their oral health conditions, because it's key. We can't only focus on managing their diabetic conditions. If we ignore their oral health status, we are doing a serial disservice to these patients. Now quickly to my presentation, and hopefully we'll have tea on time. Now, I'm going to touch briefly on a few aspects of the GEMS dental program. And as I said, we've got a dental virtual roadshow that is coming very soon, where we'll talk about more issues that relates to the program. So firstly, from a benefit point of view, just to remind ourselves of the changes that actually happened when we moved from 2025 to 2026. So the first one is on Tanzanite one. So as you will know, as from the 1st of January 2026, Tanzanite ones for in-hospital procedures, it's a PMB only cover. And this also affect dental procedures. However, the scheme made a consideration, a very serious consideration, to say for dental conditions, for the surgical removal of impacted teeth, and for children who require treatment in hospital, children under the age of 6. So the scheme made an exception that these can still be treated in hospital, but only as day procedures. So two things really here is that let's think carefully before we admit patients in theater. Is there perhaps a possibility for us to manage these patients out of theater? And where really there's a need for us to go to theater, let's consider day clinic or day hospital. And hospital groups will tell you that dental procedures, we want to do them as in day clinic or day hospitals. The second change relates to the Ruby option. So members and beneficiaries on these options are now required to use a GEMS hospital network. If you use any other hospital, this will incur a co-payment of 15,000 rand. The last change, more dental related, is on dental benefits. So previously, our traumatic restorative treatment was only a benefit for oral hygienists, so that has been extended to include dental therapists and dentists. And we apply the other managed care protocols that we apply to restorations of fillings. This slide just talks to some of the industry changes that are coming that we want to share with you. So on regular basis, GEMS reviews, coding amendments, and updates that come from the South African Dental Association. So currently, GEMS is sitting with three matters. One, SADA proposed to make changes and updates to 12 dental tariff codes. So these are still under review by the scheme. The second issue is the issue of dental laboratory or dental technician codes. So I think a couple of years, the dental associations of technicians or laboratories issued a completely new dental coding. And the basis for that is that they are of the view that there's new technology and materials that are actually not covered by the previous dental laboratory coding. So again, the scheme is still reviewing this. The last part relates to the introduction of a modifier code M8004. So some of you might be aware that there is a move to phase down the use of amalgam. And this is part of the Minamata Convention on Mercury. And the idea here is to try to reduce the use of mercury or the availability of mercury in water and in the environment. So as you know, amalgam restorations contain mercury. So our country, as part of signatory of that convention, responded. So the Department of Ministry, Forestry, Fisheries and Environment issued regulations that says if in your practice you handle amalgam, you need to have what we call an amalgam separator. What this does is that it actually captures and retains amalgam so that it doesn't go into the waste stream and end up out there in the environment. So you capture it within that particular instrument. And this is mandatory. Compliance is mandatory. For as long as you place or remove amalgam, you will be required to actually have this particular instrument. So what SADA is proposing is that to assist practitioners who actually buy this particular apparatus, we need to come with a modifier, sort of try and reimburse them. So in all these proposals, please hear him out. The scheme does not pay for any of these changes currently. As you will know, GEMS reviewed this, and at the end of the year, GEMS will communicate to all practitioners to say, these are the changes that we have made. Because you'll get advice from either people who sell this amalgam separator or from any other dental practitioner to say, you can start claiming for these particular procedures. That is not the case. Please wait for official communication from the scheme. I'm not too sure if this is visible. Is it clear enough? Yeah. So this is just for sharing. So the scheme applies what we call managed care protocols and rules for many of the procedures. And the scheme relies on both international and international guidelines. Now, when it comes to the use of dental radiographs, we rely mostly on the American Dental Association guidelines as a guide in terms of how we actually structure our guideline. So, please reduce it a bit. Let's go to the original size first. Okay, yeah. Is it visible now? No. Dr. Mpagi, can you see it? No. Okay, we'll blow it up. But what I wanted to say, if you want to read the full document, there is the link. But essentially, my interest when I saw it was in terms of how the American Dental Associations make proposals on the type of radiographs that you can use for your first patient when you see them. And it categorized them by age. Yeah, you can blow it out now. Let's go to the first group. Yeah, I think that's fine. So as you can see, on the first group, so these are children who don't have permanent teeth, so probably below the age of 6. So they make a suggestion and recommendation to say that for this patient who are new, these are the type or combinations of radiographs that you can use. Firstly, they recommend that it's either you use periapical X-rays or occlusal or posterior bite wings. So those are the only X-rays that they recommend for use for new patients. Then the next 3 categories, all of them, they recommend 2 types or 2 combinations. One, they say it's either you take posterior bite wings with panoramic X-ray. They don't talk about periapical X-ray. Or they say bite wings and selected periapicals. Dr. Mashir. So it's 2 categories. It's either bite wings and periapicals, or panoramic with bite wings. So it really talks to how we currently prescribe or dispense, our radiographs. So we use different kind of combinations. We basically throw all three of them. Panoramic, periapical, bite-wing X-rays. I'll talk more about this later in my presentation. I just wanted to share this with my dental colleagues. And as I said, if you want to read more about this, there is the link. It's a 30, 40-page document. Now, in these slides, really, what we wanted to highlight is that most of you will know that on regular basis, the scheme seeks to have engagement with practitioners. So we wanted to try and clarify the reasons why in certain instances that will be the case. And this, my experience is that these are very positive relationship building engagement. They help practitioners at the end of the day to actually claim correctly. Now, by and large, most of the engagement are initiated by what we call member dispute. So your patients call us and say, I've got an issue. I've got an issue because practitioner A charged me what I think is more than what I got. So they disagree with the cost of treatment that you provide them. Or secondly, they say, I don't understand the treatment that was done. So we simply don't take time to actually explain to them what we are doing. The worst part is where your patient says, I don't know Dr. Mashir. I don't know this person who's claiming from a medical aid. What seems to be coming to the fore now is members who are treated during wellness days. So different companies invite different practitioners to come provide services at their premises. And most of these patients are under the pretext that this is for free. They are not going to be charged for these services. And they get surprised when on the remittance advice. And let's face it, our patients are changing. The profile of our patient is changing. Some of these patients understand what a periapical X-ray is. I read an affidavit some other day. The patient said, I went to this particular practitioner. They took 2 periapical X-ray. They didn't say they took X-ray. On the affidavit, it says they took 2 periapical X-rays. They did 2 fillings at the back, but they claimed for bite wings. They didn't say they claimed for other X-ray. They said they claimed for bite wings, so they know what they're talking about. Our patients are educated. They're changing. Profile of our patients are changing. And then, on the other hand, as you know, medical aids pays claims in good faith. So you submit a claim. All that a medical aid sees there and then is to say, is the membership valid, tooth number, tariff code, IC10 code, procedure, does it meet the clinical rules? And then get paid at that point in time. And as you can imagine, GENS processes a lot of claims on each and every claim run, so it's impossible to sit and review each and every claim. However, over a period of time, then we go back and try to understand and see what's happening. And if there are things that sort of we want to clarify, then we'll seek to have those particular engagement with yourself. So please don't run away. When we say let's talk, we want to clarify certain things. There's somebody who will come after me after tea with big beard. You should be scared when it comes to me. Me, I'm very friendly. We talk about clinical issues. So let's engage when we request that we have this engagement. This slide, I just wanted to show you that in 2025, a total number of 443 providers, dental practitioners, were affected by member dispute, where members said, look, this doesn't make sense. And in total, we have around 4,000 claiming dental practitioners. So it's around what, 10%? Somewhere there. So that's a lot. And the last line where it says treatment not done, again, 590. And again, the disclaimer is that this might be duplicated. 590 claims that said this treatment not done, it can be. Now, in summary, this slide highlights our top 10. Yeah, the clock is on it's obscuring my slide. Thank you very much. Top 10 claim rejections. And obviously with a view that we start reducing some of these things. And some of these things are really, really administrative. So we should be able to know before we actually finalize the claim that, this claim is going to get rejected. The toppest, highest rejection reason is mainly on amount exceeded. So GEMS, the scheme has its own tariff amount. And if you're part of the network, and obviously you can't charge above scheme rate. So it's really surprising that the top rejection region is where practitioners charge above the scheme rate, and the next one is where maximum financial limit has been exceeded for the year. And thirdly, it's the issue on restorations, colleagues. You know that GEMS have changed the managed care protocol, time rule and restorations. Those can only be replaced after a period of 2 years. And this is still very conservative. You'll know that, if you look at systemic review, says a restoration can last anything between 5 to 10 years. But GEMS still says we'll be very conservative and allow it within 2 years. But still, we still have this that is actually happening in less than 2 years. Now, the next couple of slides, just an overview of what we observed in terms of claims and benefits that the scheme has paid. And here we're mainly looking at 2025. We look at the three dental disciplines: dentist, dental therapist, and oral hygienist. So the first thing that I want to highlight here is benefit paid between 2024 and 2025. So we're interested to say, in terms of benefit paid out, what was the change in percentages? So overall, when you compare the three disciplines, if you compare benefit paid in 2024 to that paid in 2025, we saw a 7.4% increase. So if you compare 2024, 2025, 7.4. When you strip them out, you look at dentists, year on year, it came to 7.1. So very close to your average for all dental disciplines. Dental therapists, slightly concerning. So if you compare 2024 to 2025, where it says grand total, we're sitting at around 87.7%, far above your average of 7.1. It became worse when you go to your oral hygienist. This oral hygienist, very volatile because there are very few in numbers. You've got 30 practicing, and in a short space of time, 10 new come into the market, then it just throws everything into this array. So we saw a higher increase of around 57.5%. But what I also wanted to highlight here is just to look at Limpopo in isolation. So if you can go back to the dentist slide. Yeah. So there's Limpopo. Firstly, the red line, so that's your year-on-year increase, as I said, around 7.1, comparable to your average increase. What we also wanted to indicate here is the average paid per patient. So on average, we pay 2,200 to a typical GENS patient to a dentist. So again, Limpopo not very far off, so it's sitting there in fourth position. Where we're paying more, it's KwaZulu-Natal, Western Cape, and the Free State. So those are the provinces on an average pay per patient are costing the scheme higher. Let's go to dental therapist. Third from the bottom, so from an average pay per patient, also slightly lower. And then the last one, oral hygienist. So your grand total there just behind Gauteng, and again, oral hygienists are actually sitting fifth. So we sort of somewhere in between, not leading the pack and not behind the pack. If you can go to the next slide. So the next three slides, again, we look at Limpopo, we compare it to the national average. Here we're looking at top 10 procedures that are claimed by different disciplines. So three measures that we're looking at, we're saying claimed quantity per patient. We also look at the percentage of patients who actually receive that particular procedure, and we also look at the ranking in terms of the, yeah, so we look at the ranking from 1 to 10. Now, from when you look at dental therapists and you compare your claim quantity per patient, it's comparable to national. So your national is on the right-hand side, and your Limpopo on the left-hand side. So your 2.2, for example, for your 83608 compared to 2.3. So it's almost comparable in most of your average per patient. However, where we see a difference between Limpopo and national, it's on anterior restorations. So Limpopo seems to emphasize more on your anterior restorations. So if you can point to the bottom, your 8353 and 8354. So combined, you're looking at around 16-17% patients who received anterior restoration compared to around 12 nationally. If you can go to the next slide. Dentists, again, in terms of claim per quantity, comparable. For example, oral examination, it's 1.1 versus 1.1, so it's comparable. And again, the percentage of patients almost comparable. However, what we see mostly emphasized in Limpopo is the issue of x-rays. Limpompians are very high on x-rays. So 8107, 8112, 8115, they combine all three of them indiscriminately. So higher percentage of patients are getting panoramic X-ray. As you can see, we're sitting at 27.8% versus 20.6%. Bite-wing X-rays, 35% versus 21%. In isolation, it's fine. It's only when all three of them are combined on the same patient. And it brings me back to that ADA guidelines to say, let's be selective in terms of which X-rays we use. If you use a panoramic X-ray, it means you're going to use few bite wings. If you use bite wings, it means you're going to take few selected periapicals. But we know the practice. The practice is that even when the patient gets seen by a dental practitioner, they are sent for an X-ray. What informed the X-ray? X-ray needs to be informed by oral examination to say, I need this kind of X-ray, I need this quantity of X-ray. Next slide, please. Okay, and then lastly, oral hygienist. And I need to if there are any oral hygienists in this room, I really want to congratulate you. If you go to 8163, A preventative procedure, 8163, please. Fissure sealants. On average, 6.2 per patient. And almost 22% of the patients who visited oral hygienists in this province are getting fissure sealants. You compare that to national average, 4.8 sitting at 4.1%, which is very low. And the scheme made this as a preventative procedure. And further down, if you go to 8161, please. Again, topical application of fluoride, a preventative procedure. 16.2% of patients. Commendable versus 7.9% that we see at national level. There are two procedures that we have a problem with when it comes to oral hygienists. 8228, if you can go to 8228, please. And again, commend oral hygienists in this province. We're sitting only at 8.5% of patients, while nationally 52.7%. Grossly abused, especially in my adopted province, Gauteng, is a problem. Next slide, please. So in closing, here we want to share a few coding that we still have challenges with. We're doing well. We're doing better than the last time while we were here. We raised a lot of issues about some of these things. But we're seeing very few practitioners having these issues. And these are probably people that we haven't engaged with before. We're still seeing challenges with Tariff Code 8104, limited consultation, just misinterpretation, lack of understanding that, this code can only be used once you have actually finished your treatment plan. Before you finish your treatment plan, you can't claim this code again. But we're seeing instances where practices are saying this for repeat patients. So patients come back for restorations that you haven't finalized, or you're busy with a crown placement, root canal treatment. They throw in this tariff code. Ishmael will say the HOI. So they just somewhere HOI, 8104. There are still practitioners who don't understand the difference between 8166 and 8167. So they'll use a medicament for treatment of sensitivity, but instead they claim tariff code 8166. Periodontal screening, still slightly a problem, but the problem has shifted now. It's more about the age. What are you doing periodontal screening for a 12-year-old or 10-year-old routinely in your practice? So now it's more of the age. It's no longer about charting. Now they understand to chart, but now is the age. Big problem. 8937 versus 8201. Surgical removal of a tooth and a normal extraction of a tooth. So there are two groups of practices. There's one group of practice that says a permanent teeth extraction is a surgical removal of tooth, and therefore charge as such. And they only use 8201 for your primary teeth. And then the other group, just every extraction is 8937. But that's not what we were taught, that an extraction is a surgical removal of teeth. We use our hands, but there's a scientific basis in terms of what we do and how we do things. That's why Dr. Likhodi spoke about separating at, is it fourth year? Dr. Mpak. You don't remember. So how dentists and medical practitioners separate at some point, we just don't use our hands. We learn medicine, we learn science, the scientific basis in terms of what we do. And here's an open secret. We have identified these practitioners. We have engaged them. If there's no change in behavior, especially on 8937, we're putting them on pre-auth. Come 1st of June, 8937 for these particular practices, pre-authorization before you do them. The last one is the issue of root canal treatment. Most of practitioners are starting to struggle, and some are misinformed by other practitioners out there to say, if you use prep visits, you paid less. Rather use your complete therapy when you claim for root canal treatment. So there are two approaches in terms of how you do root canal treatment. One is a one-visit approach. You come in, I remove the content of the pulp, I fill them, you're done, finish, klar. The other approach, which most practitioners prefer. First visit, you prep the canals. They come back, you obturate. But you can't mix the code for the first approach with the second approach. You can't want to claim for complete therapy and then after that, obturation. It doesn't make sense. Complete therapy, it means I'm done with you today. I don't want to see you again. So you can't on another day claim for obturation. But it's complicated. The coding is complicated. We are available to assist. Don't just take advice from other colleagues who claim to know how to do this, because you're the one who end up in trouble. You're the one who end up in trouble if you claim incorrectly. That should be my last slide coming. Oh, I forgot that. Okay. X-rays, two things. We're picking up practitioners who are sending us the same X-rays for different patients, for authorizations. So you know that Dr. Chauke came to you, she needed crowns, you took X-rays. Based on those X-rays, we approved crowns. Now you took the same X-rays, used for another patient. The second phenomenon is this of panoramic X-rays. And the providers that we engaged said we were advised by the supplier. So you go to a supplier sells you a panoramic machine and say, you know what, you can take a pen, claim for a pen, divide it into two, and those 4 are bite-wing X-rays. So you can claim for bite-wing X-rays and periapical on this same picture. And we know the definition of a bite-wing X-ray. It's an intraoral X-ray, firstly, but secondly, it needs to provide you with different legal information from what you see. This is the same thing. And there are a lot of practitioners who, when we engage, said we are advised by the supplier that I can do this. Supplier didn't teach you at dental school, were they? Were they there? Nope. My last slide, as I said, we initiated what we call the dental virtual roadshows. There was a delay in having our first one, which we will be having on the 10th of June. So you will be getting invitations during the course of this week. And again, the first hour will be used for a clinical lecture or clinical presentation. So we'll focus on the use of traumatic restorative procedures because we know it's an issue on the oral hygienist side. And now we have extended the benefit to dentists and dental therapists. The second one will be somewhere in September, October. And again, now we will be zooming to a more controversial issue, the issue of dental radiographs. So we already have spoken to a maxillofacial radiologist who will actually do a clinical presentation on that particular day. So again, we'll allocate more time for any questions or any queries if you are unable to deal with all the questions today. That's the end of my presentation.
Thank you very much, Dr. Paddy, for the presentation.
Oh, the
Patient-
story. Should I finish it? The Matume story. Okay, no, I won't.
No, don't finish, Mato. I was not part of those kids. I was the nice one. I'm the one who lost. Ladies and gentlemen, we're going to take only 3 questions. We're going to take them all at a time. Then Dr. Padden will note them. Then he will answer them. Then we'll go into break. Okay. First, Pagania. Congratulations on winning the league.
Yeah, thank you. Thank you, Dr. Maluleke. As they introduced me, I'm a Pakachuchu. Soon to be champions in less than 8 hours. So I'll be your champion. Then coming to
Done with this question.
the question, you spoke about X-ray, of which I think we are having an maybe big issues on that one, especially when we take periapicals and bite wings, to say that maybe we are overexposing and we are taking more of them is something else. But the issue is that the reason why we take X-rays, especially, is to determine whether there is a existing or there is an issue with what we wanted to see. But when you take an X-ray on the first visit, then 6 months later you take X-rays, it becomes issues to the medical aid to say that why we are overexposing these patients, why are we taking this many X-rays? But the issue that we are experiencing in the clinics is that we don't take those X-rays. 8 months later, we do not pick it up clinically. And 1 year later, the patient comes and said that, but last year I was here, you did not see it. Why? That's what we are experiencing. And that's why maybe the X-rays in this part of the world, there are many. It's because of that issue that we've seen these issues. Patients have been complaining to us to say that you failed to pick it up. As we mentioned it correctly, to say that patients now are more educated than the previous generations. So that's why we want to get the balance, to say that how do we get the balance in taking the X-rays? And what does the science tells us when we take these X-rays? And what is that we want to achieve when we take these X-rays? So that we can balance it in claiming and in determining the diagnosis. Yeah, thank you.
Thank you very much for the question. By show of hands. Oh, thank you.
All right, good morning or good day, Dr. Padden. We've been here in 2024 in this very same room, and we have actually given you our complaints or the things that are bothering us in the dental field. And till today, you have not implemented even one of what we have actually expressed that day. And it was a very intense and emotional meeting, if I recall. So it tells me that you keep calling us here, but you are not taking us serious. Question is, what's the point of this meeting if we are not going to be heard? This is a relationship. We are trying to meet each other halfway since we don't have any platform where we can engage. But when we come to you and we say these are the issues in dentistry, you listen, you note them down, and you ignore us. That is something that I just want to answer me there. What's the point of this meeting? Question number 2, it is on the issue of rejected claims due to the scheme rate. We understand the scheme rate very well, but then one other thing that you don't understand as the scheme is that we are the ones that are dealing with the clinical problems. if the patient comes to me with more carious teeth, maybe 10, and the money is there, what is stopping the scheme from paying more teeth than the ones that you say we are doing too much? Because this thing of scheme rate is like we are exceeding the amount that you have given us. Ne? So now we are trying to help the patients. And this has been a problem. In 2024, I asked you this question, Hori. What measures do you have as the scheme of helping our patients not to take too much sugar? Because before we can talk about them having decayed teeth and not treating all of them because of whatever reasons that you have, question is, do they know that caries comes by them taking too much sugar? Are you involved as a scheme into the food industry, whereby we must teach the patients, or your clients, you must teach them? Ne? I don't know if that one is a question, but it's a question of saying, are you involved in helping them not to take too much sugar? And also, what's stopping the scheme from paying if the money is there? Because at the end of the year, we leave too much money into the scheme, and you take it back in the form of forfeiture. But the patient is there left with the pain. They did not get treated. They have 10 teeth that are rotten. Why can't I fill all of them and help the patient? Question number, I have many questions, I'm sorry, you have to write them down. And the other question is also on the fillings. Ne? We are coming back to the food industry again. I said this in 2024, I'm still going to repeat it. The tooth has 5 surfaces, right? I send a claim that filled 2 surfaces, and then you pay me. Then the patient continues and eat sugar as they do every day. Then they go to Dr. Pitswane, one year from me. Ne? They go to Dr. Pitswane. Dr. Pitswane examines and finds that the patient indeed has a decay. But this decay is a new lesion. Where Dr. Mashuru worked, it is still intact. On the X-ray, the restoration is there. Clinically, the restoration is there. The patient is not complaining on that side where Dr. Mashuru worked. She is having a new lesion. And Dr. Pitswane, as a responsible dental professional, she is going to do what she was taught at school, help the patient, relieve the pain of the patient. And then when she sends the claim, medical aid says, no, we can't pay you because we paid Dr. Mashiro in 2023 or 2026, sorry, 2027, whatever. So now, why are you not having ways of finding out, or Dr. Pitswane, when you're saying this tooth that was filled a year ago, it needs to be filled, what happened? Now you're punishing the patients over something that is simple, that you can actually come up with a way of checking. Oh, Dr. Mashiro filled this side. We all know the sides. But then Dr. Pitswane is talking about another side. If Dr. Pitswane is saying she's filled the same side as Dr. Mashiro, then that is a problem. So you are punishing the patients, Dr. Maluleke. Question, Engwe, Arafech. We're still going to address the issue of children. Now, I am surprised to realize that you are saying we can treat children of less than 6 years. Less than 6 years, does it include 2 years, 1 year? Because according to Road to Health booklet, as dental professional, a child is supposed to be seen from 12 months. Ne? But as far as I know, the interaction that I've had with the scheme is that you don't allow us to touch the kids before they are 3 years. Unless that has changed, you'll forgive me there, right? Now, my question there is, why do the children do the children have a dental cover from birth, but then you're saying we must not touch the children before 3 years? What is the purpose of that dental cover if we are not supposed to? Besides the other dental issues, there is another big case called ankylosing. Ankylosing is tongue tie. We all know the oral cavity is it's important in speech development of children. So if a baby is born with ankylosing, now me as a dentist, I see the patient and I say, I want to relieve it. You, as the scheme, are saying you're not going to pay me because I'm not supposed to touch the child before 3 years. What is that? Why are we not supposed to be helping? I know that these cases, not everyone sees them, but we've been doing this from when we were still working at the Department of Health. Now, when we are in our private practices, all of a sudden, we are not supposed to treat ankylosing. Who's supposed to treat it? Because that's our field. I hope it makes sense. I have many, but let me pack it here and give others a chance. Thank you.
Thank you very much for the questions. Ladies and gentlemen, I think we can agree that our basket is full of questions. We will stop it there. Dr. Padin, the stage is yours.
I'll start with the last one. And I forgive you, Dr. Mashego. I forgive you because the scheme has no broad age restriction on dentistry. We've got procedure-specific limits, lower and upper age restriction. But there's no scheme rule that says a 2-year-old, a 3-year-old cannot see a dentist or a dental practitioner. It will actually be self-defeating for any scheme to actually do that because you want to prevent oral health condition from an early age. Yes, the scheme will say to you, for a child who is below the age of 6, we don't pay for panoramic x-ray. But there's no rule that says a 2-year-old cannot see a dentist. So I forgive you on that. The issue of scheme tariffs, I think we're missing each other here. Scheme tariff says, for 8368, I'll pay you, and it's a rough figure, I'm not giving you the exact amount, I don't know. Say, I'll pay you 868 rand. That's a scheme tariff. If you decide to charge above that 868, or you charge 900 rand, the scheme won't pay the difference. That's the scheme rate. What you are talking to is the issue of quantity limitation, where the scheme says, for members on beryl or tanzanite, you can only have a maximum of 4 restorations. I think that's what you're talking about. Now, on instances where you as a practitioner, because remember scheme set rules looking at average of numbers. Average of numbers says they are outliers. The question is, how do you deal with outliers? GEMS has an exception management process, and this also covers your other part of the question where you have placed a restoration on the occlusal surface. Distally, dental caries develop 2-3 years down the line, and the patient goes to see another dental practitioner. It will be incorrect, after having followed all the processes, not to pay for that particular claim. So the key here is following all the processes. An exception management process where the second practitioner says to us, this patient was seen by Dr. Mashego. They did an occlusal restoration. The patient now presented with an interproximal caries. If the second practitioner submits an x-ray that shows that, we pay for that. We pay for them on a daily basis. And these are some of the things that we spoke about previously, Dr. Mashego, whilst we were here, to say, don't go away. Appeal, exception management process are there. And that's what we do as clinicians, to say, does this make clinical sense? And if it makes clinical sense, we pay for them. Bagabag, I wish you all the pains this afternoon. So you asked the question and basically you answered it yourself. And as I said, in isolation, if you take a pen by doing periapical, nothing wrong. Nothing wrong. The problem comes where we over prescribe radiographs. And I ask you a question. What more do you see? You've taken a panoramic X-ray, and then you take 6 periapicals. What more clinical information are you getting there on 6 periapical while you've got a panoramic X-rays? And given the modern technology that we have, some of these panoramic X-rays that are available, you can even see dental caries. So what we're saying here is that we're not saying don't use X-rays, but we're saying let it be informed by the clinical information that you get after looking at the patient. And as I said, the practice is I come to your rooms before you even see me. Your dental assistant take me to a room. Pen X-ray, bite wing, periapical. You don't even know clinically how I present. Because one of the guidelines is clinical discretion and risk. Let's use X-rays based on the risk of the patient. Even when I come back, I came to you with no dental caries. No dental caries. You took bite wings, you take a pen. And again, you're taking 4 bite wings. Clinically, I present with nothing. I come to you every 6 months. Why should I continuously have X-rays if I don't present with dental caries? At my age, can I develop new dental caries? And that's a clinical question. Hence, I emphasize the issue of what does our clinical training says? Can I develop new caries? I can have then secondary caries. I can break a tooth. I can't develop primary caries at my age. Can I? I can fracture a tooth. I can have secondary caries. But I can't have new caries. So the issue of X-rays, as I said, we'll discuss it more in our second dental virtual roadshow. My invitation to you is that please read that document. There's a link. I'll ask that we share that link. Download that document. Read it thoroughly. We have invited a maxillofacial radiologist who will take us through the issue of X-rays. But I stand here in front of you and say, if you have taken a pen, you can't be having 6 periapicals. It gives you no new clinical information. Thank you. But again, let's meet on the 10th and talk more about dental issues.
Thank you very much, Dr. Padin. Let's give Dr. Padin a round of applause. Ladies and gentlemen, we've just flighted the agenda so that you can plan accordingly. We have exciting program afterwards. We still have Mr. Mohapi Ismail as well as Dr. Kubeka Chauke. But for now, we're going to break for tea. But before we go, ladies and gentlemen, we'd like to, Dr. Padin, Dr. Lehodi, they are still around. While we're having tea, it's an opportunity to engage with them. We also spared stops. We still have our SPNs. We always hear when we engage providers as a provider liaison officer that, who's your manager? I want somebody senior because you can't give me the answers. So everybody's here now. Management, PLOs, SPNs, outside there are live systems, the same systems when you call and confirm benefits. It's the same systems, they have laptops which are there. Should you have any queries, please take the opportunity and engage with them as well. So yes, we are going to break for tea. Let's see what time we'll be back. At 12:15. If I'm not missing anything that I need to announce, I will check with my team. Oh, ladies and gentlemen, please do not forget, this is a CPD accredited occasion. So when you come back, I hope you also registered for the first sessions, the morning session, session 1. Now we're coming back for session 2. When we come back, please don't forget to register. for the second session as well? Or we'll be back at 12:30. Please, while you are there as well, please do not forget to register for the second session as well. Thank you very much.